good afternoon from Singapore, the Center for Behavioural and Implementation Science Interventions at the Yong School of Medicine at the National University of Singapore, who is hosting this webinar. I am Nick Sevdalis. I have the pleasure of being a professor at the school and the academic director of the center. And today, I am your host and facilitator for what I think will be a wonderful, very topical and very exciting and interesting conversation that we will have with three experts from the country and beyond. So welcome to all of you in attendance. I would like to introduce our expert panelists for this webinar this afternoon. So I have the pleasure of having with me today Associate Professor Mythily Subramaniam from the Swiss Hock School of Public Health at the National University of Singapore. So Mythily, a very warm welcome. I'm also delighted to have on this panel today Professor Claire Henderson, a clinical professor of public mental health and a practicing community psychiatrist from King's College in London. Very pleased to say that Claire is joining us from Singapore, where she is a visiting professor with the BISI Center in our School of Medicine. And last but not least, Mr. Caleb Tan, an assistant director at the Ministry of Health Office for Healthcare Transformation and in charge of a major task, which is the leadership and implementation of a major online mental health service platform that we will hear about more from Caleb in the course of this webinar. So essentially, I'm delighted to be joined by hundreds of you, as we normally have in these events. Today, we will be talking, debating and reflecting on aspects of implementing complex mental health services, mental health programs and interventions. The title of today's webinar is From Stigma to Systems, Implementing Mental Health Interventions that Work. What we really want to be doing today is to be reflecting on aspects of implementation, scale up and sustainability of interventions, programs and platforms that are designed and implemented to improve mental health outcomes at scale. We know that stigma is often discussed and found in the literature as a major barrier to such implementation or to the uptake of such services. Is it the only one? How does it compare to other considerations, other determinants? What other things we need to be thinking about in addition to stigma when we're implementing such programs? How does stigma interact with other aspects, other determinants of these implementations? These are the sort of discussions, the questions that we want to debate and reflect and discuss with our panelists. And of course, I would like to encourage all of you to contribute to that discussion. The way we normally do this is that you can find the Q&A button at the bottom around the middle of your screen on your Zoom interface. So please use that. You can put any question you like to our panelists. What we'll try and do is to sift through those questions after an initial round of our panelists presenting some of their own work and perspectives on these topics. You can also upvote questions that other people are putting through, so we can see which questions are more of a priority for all of you. We want this to be a really energetic and useful debate, and to be addressing questions that are really at the forefront of your thinking and of your work. So please do use the Q&A panel. I will be checking that as we go through the webinar. Do not use the chat function. It has been disabled. This is just for us to be doing our sort of back office operations and make sure the webinar runs operationally smoothly. The Q&A function is the only one that is available to bring forward some of your questions. So this is what we're here to do. This is me setting the scene. So I will now I'd like to invite Prof. Mythily to start us up, share some of the work that you are doing and some of the considerations around implementing, scaling up, sustaining that you have faced, and perhaps how you might have gone about addressing those in your research around mental health service implementation. Look forward to having your original sort of, if you like, description, so we can get us going and think about these aspects. Please, Mythily, on to you.
But before that, a very big thank you, Nick, to you as well as to BISI for giving me this platform to talk about my research. And I think I will largely focus on research studies, which surprisingly are also affected by stigma in terms of participation. But I also like to think that some of our research studies, if done properly and with the proper aims, they also help to dispel stigma as well as overcome some of the barriers. So one of the studies that I wanted to really highlight at this point is a study which we have just embarked on. It's a study called PREDICT. And in this study, for the first time, we have very bravely gone and said that we will be preventing depression. And again, that was done in a very, strategic, after a lot of thinking, we decided on it because we felt that it is time to say that mental illnesses can be prevented. They are no different from other illnesses. If you do take some of the precautions, you focus on some of the strengths, of course, there will always be a group that will still have these problems, but you could prevent it. The other thing that I think which we really did was to talk about the dimensionality of depression and not just see people as either, having major depression and then they are completely normal, but we do acknowledge, and we have stated it very clearly in our multiple collaterals, that it is a spectrum. What a person may be completely healthy today, and over a period of time, they may have some depressive symptoms, and if untreated, they can become depression. And then similarly, a person with depression can come down and, be perfectly normal. They can recover, they can be perfectly normal. And so what was interesting about this study is we did a similar study, but not exactly the same. And we had gone out about, I think, 15 years back, and we had tried to invite people to participate in our study. And our response was really, really poor. Like, people were not willing to take part in a mental health study, and they were not willing to come to the Institute of Mental Health for any kind of assessment as well. This time, we launched the study online about, I think, a month back. We have 300 signups. We are still trying to get back to people. And I think it is important how you present it, and it's also important in research studies also to think about some of the barriers associated with stigma.
Thank you very much, Mythily. That's you're already pointing out some things around how you implement, even as you're saying, a research study, let alone an actual clinical or health service. So something to think about in terms of how they're positioned to their audiences. So thank you very much for that. I will now invite Claire to share her angle in terms of the research that she's done on stigma and in relation to some of these interventions, Claire, that I know you've developed, evaluated, and implemented. On to you.
Oh, and thank you very much, Nick, and to BISI at large. So I'd like to invite the audience, first of all, to do a thought experiment. So you wake up in the morning, and on this particular day, there is no more stigma. So the first question that arises, I guess, is, how would you know that stigma has just gone? And I guess one thing that could happen is that, you greet somebody at work or family or whatever, and you say, how are you? And instead of what we usually say in England, which is like, yeah, I'm all right, thanks, somebody says, good days and bad days, and, not too bad today. And you'd be quite surprised that they had shared, a little bit more than usual. And if you're a mental health professional, you might find that instead of having some no-shows, everybody shows up. You suddenly have a very long waiting list, and a lot of referrals. Or it could be you show up to work and suddenly you've got lots more colleagues because there's lots more funding to employ more people to meet the extra demand that would be generated from having no stigma. And then you would see your patients, and you would find that on talking to them, their social networks were much more intact. They were much less socially isolated than a lot of people become. So they've got much better social support, and that as a result, then rehabilitation becomes a lot more feasible, and people are more willing to take up new social or economic employment opportunities because they're not so worried, for example, about disclosure about their mental health problem. And of course, they're also more willing to accept treatment. So this all is designed to show really that stigma makes implementing kind of everything in mental health care more difficult. On the other hand, stigma reduction is possible, and this needs to happen at a number of levels, preferably all around the same time. So very often anti-stigma programs or stigma reduction programs will focus a lot on public stigma, so on dispelling stereotypes, and doing that by providing people with contact-based education or social marketing. And that may be virtual through adverts, social media, etc. But it also may be face-to-face for particular kind of target groups. And that is really to, like I said, dispel stereotypes, give people the idea that, the recognition that people recover and can have valued social roles in spite of sometimes having continuing symptoms. But there also needs to be structural level changes, as I referred to, in terms of things like funding for mental health services. And in some countries, changes in legislation and policy are required to go along with that. There's also an emerging evidence base for psychological interventions to reduce self-stigma or its internalisation, which can make people feel quite alienated, quite hopeless, as if there's not really much point in kind of trying to do very much because stigma is going to just get in the way. So as I've indicated, a reduction in stigma is going to lead to increased demand in services. And I think this is something that we have seen in the UK. And as I said, we have to address stigma on the structural level at the same time as the interpersonal and the kind of public stigma level, because without that, the increased demand can, I think, lead to a bit of a backlash. So in the UK at the moment, there's a certain kind of political and media narrative about particularly young people not being very resilient. There's this a phrase about the snowflake generation. There's a concern that more young people are not working and are relying on welfare benefits instead. And that is really a response, as I said, to an increased demand due to partly a reduction in stigma, but also to worsening mental health amongst young people. So the implication is, we need a service response to the worsening mental health and increased disclosure as a result of stigma. But that response doesn't necessarily have to involve lots of very highly trained mental health professionals, which obviously comes at a very high cost, because the response can make use of reduction in stigma. For example, we're seeing group cognitive behavioural therapy in schools taking place, cognitive and behavioural therapy being led by parents delivered to their children, and adult education and sort of co-produced adult education response in the form of recovery colleges to help people with self-management, digital platforms. So things which are more cost efficient, and as I said, can make use of that stigma reduction.
Wonderful, Claire. Thank you. So you're clearly helping us here to think about different levels of stigma and also different levels of intervention. Again, following on from what we've heard from Mythily, sounds like there's several strategies that could result in higher uptake, but we should come back to this, not least because of what we do and how we manage that higher uptake is something that we need to consider as part of any implementation sort of study and indeed planning. And with this, I will move on to Caleb to take perhaps the perspective of someone who's dealing with all this on a daily basis and looking at what's the offer, what's the demand, what's the uptake. So Caleb, please do share your experience of essentially implementing a very scalable and intended to be scalable and sustainable platform to address mental health concerns and to absorb some of that demand. Look forward to hear about it.
Thanks so much, Nick, and hi everyone. Thanks for having me today. And I was just reflecting on what Claire said about snowflake generation. I remember in my generation, people call us the strawberry generation because we were easily bruised, easily hurt. But I think we all sort of go through different stresses in our lives. And just to introduce myself again, my name is Caleb. I lead partnerships for Mindline at MOHT. For those who are not familiar, MOHT is the Ministry of Health Office for Healthcare Transformation. We design and implement innovative solutions to drive healthcare transformation in Singapore. So mindline.sg is the project that I work on. It's Singapore's digital first stop for mental health. To share a bit of background, we started in 2020 at the height of the pandemic, when we started seeing people getting stressed over the fear of infection, fear of unemployment, burden of caregiving, etc. And together with our partners at the Institute of Mental Health, National Council of Social Service, and Ministry of Social and Family Development, we put together a resource hub in 2 months, very quickly, to help users find the support that they need. And the idea was then to provide an anonymous, credible site for our users and our residents to find the help that they require. So why anonymous? I think the important thing that we are discussing about today is stigma. And in our early days of research, we found that having anonymity helps to reduce the barrier to entry and helps to address the inherent stigma that people face when seeking mental health support. So we wanted to lower the barriers as much as possible, so that when users come and seek help, they are able to get the help without having to put in information and share too much details about their current situation. Since then, we've grown quite a lot. We've expanded to support working adults through Mindline at Work, to supporting young people through Youth Mindline. We're also very lucky to get support from various partners in the industry to address subpopulations like teachers and healthcare workers who face very different stresses from the generic populations. On mindline.sg, users can do a very simple PHQ-GAD assessment. It helps them understand their anxiety and depression state and get tailored resources based on their interests. For those who prefer to do self-help, they can read resources, watch videos, chat with a chatbot for guided exercises. For those people who prefer in-person support, we've worked with the Agency for Integrated Care to build a service wayfinding tool where users can find the most appropriate mental health service near them. And for people who prefer to call or text, recently you might have read in the news that the Ministry of Health and the Institute of Mental Health launched National Mindline 1771. So it's a 24/7 service where anyone can reach out for support. You can seek help by calling the number 1771, or if you prefer texting, as with most younger people do, you can do so through WhatsApp 66691771 or through the web chat on the mindline.sg site. So the idea is to give users a choice to determine the kind of help that they need. We don't sort of prescribe it to them. We help them through the journey in understanding what they need and give that to them. We also embarked on a 8-month co-creation journey with young people back in 2022 to create Youth Mindline. And on this topic of what Claire mentioned, that reduction in stigma is going to cause higher demand in services. That's very true, because when we were speaking to the young people, they told us that, over the last 5-10 years, there's so much awareness about mental health. They are now more aware about the mental health conditions, but they have more questions. When they have more questions, but as a young person, you already mentioned that they don't have the courage or resources to seek professional help. And the easiest way for them to seek help was to go to Google or go to TikTok and sort of ask anyone. So we saw an opportunity there back then to create Let's Talk. So essentially, it's a moderated online forum. Think of it like a Reddit and Quora merger, where young people can go in there, ask any mental health question, and get answers from verified therapists in 24 hours. It's completely anonymous. We don't ask you for any details. Just come in, ask your question, and get the answer that you need. It's not meant to replace therapy, but I think for young people, they appreciate that avenue to be able to get answers to their burning questions, because they have so many more questions nowadays. For some of you who may be a bit older like me, like you remember Aunt Agony in the old days where we can send in questions. So it works similar in a similar way. And since then, we've answered close to 2,000 questions and have also built a supportive community of befrienders to be able to support this group of people. So personally, I believe there's a lot of potential for digital mental health solutions. But as we continue to build up digital mental health solutions, we need to be mindful that it should be digital first and not digital only. So I'm really looking forward to this discussion and hearing from the fellow panelists on how we can scale such initiatives together.
Caleb, that's phenomenal. Thank you very much. There's a few things that are emerging in what you said, and I'm trying to take stock of the last sort of 15 minutes. There's about 4 themes that I've sort of jotted down, and they're also reflected in some of the questions. The questions are starting to come through the Q&A. So to our audience, please do keep them coming. So just 4 themes, not in the order that they appeared. I've heard quite a bit about tailoring. So having interventions, programs, platforms that are tailored to the need. Claire alluded to co-design, co-production in the methods and potentially the content of what we're offering people. We talked about anonymity, and this is where some of the digital portal solutions and so on seems to be coming in, even at the level of research that Mythily sort of started talking about. Caleb, you talked quite a lot about it. The capacity to absorb the demand. If we do create the demand, and we might take, whether we take the United Kingdom as a case study or any other country where we've seen in the last few years an increase in demand, perhaps also think about the sort of what you find as the endorsement in inverted commas. You've got, I remember because I spent 2 decades of my life there, members of the royal family, who is a very, very visible, salient sort of family for the land and abroad, coming out talking about mental health. And that's often seen in analysis and studies I've seen as one of the main drivers, as you would have in any social marketing campaign, having people that are recognizable to talk about something. Then you find that demand follows, but then can we do something about it so we don't just open the gates and then you go, right, great stuff, but we can't really accommodate. And therefore the scalability of digital, which of course is not digital only, but the digital first message, Caleb, comes in pretty handy. But also the fact that there might be trends over time. So we've heard about a study that 15 years ago, we look at where we are now. 2 of you talked about generational effects, whether it's a strawberry generation, the snowflake generation. I don't know what other generations coming towards us in the next few years. Are there generational effects there that we're picking up in trying to accommodate different cohorts of the population? And interestingly enough, our first question in the Q&A is actually the first question I had in my notes. We're talking about stigma. Let's first of all try and define it. And maybe, Claire, I'll start with you, then go to Mythily. How do we actually define stigma? And then the second part of this question will be, with that definition in mind, how do we actually work with it? Can we think of specific examples? So we talk about the nitty-gritty of implementing in an effort to reduce stigma, increase uptake. How might we actually do it? And it'd be really interesting to compare and contrast case studies from Singapore, but also from other countries. You guys have vast experience in all that. So should we start with that? And maybe we go Claire, Mythily first, then we bring Caleb into the second part of this. What is stigma? What do we mean by stigma? So we're quite precise about it.
Sure, thanks, Nick. Good idea to get on with a definition. I always talk about 2 different definitions, actually. So one is a kind of sociological one, because it's sociologists that have been really, working in this field for longest. And that's really talking about stigma as a process, starting with labeling. And as clinicians, we have to be very careful about the use of diagnoses because they tend to seep out into public consciousness and become a label, which tends to mean something quite different from, what we were thinking of. But it's labeling certain behaviours or types of people or problems, as problematic and as indicating illness. And then there are stereotypes that are attached to those labels. And again, that could be stereotypes of, what the illness is like. It could be, what do people with the illness behave like? Or it could be something about what kinds of people get the illness. So those are 3 sort of facets of stereotypes. And then there's the sort of distancing or separation, the othering, so wanting to avoid people who've sort of been defined as fitting that stereotype, and the kind of emotional responses to that, whether that be fear or pity or disgust, perhaps, and then at the more sort of systemic level, kind of discrimination, and that's tends to be a repeated process, whether that's kind of interpersonal or at a kind of organizational or policy level. And for that to happen sort of all the way through, to a kind of systemic discrimination, there has to be a kind of power differential operating. between those who are able to do the discrimination versus those who experience it. So if you think back to the sort of initial process of labeling and stereotypes, we have labels and we have stereotypes about all kinds of groups of people, and that might, for example, include I don't know, like I'm thinking back to the economic crisis, bankers, for example, but those people are not in a position of having less power than everyone else, and so that the whole process of stigmatization doesn't really happen. So that's a sociological definition, and then I think as well a public health definition is also very useful because it allows us to think about measurement more, and that's the sort of traditional knowledge, attitudes, and behaviour kind of. So problem of misinformation or a complete lack of information. And then the kind of attitudinal aspect, which is really about endorsing stereotypes, which happens in the kind of informational vacuum. And then the behavioural aspect, whether that is the kind of interpersonal discrimination or sort of more system level organisational discrimination.
Yeah.
Wonderful, thank you, Claire. Mythily.
I mean, first of all, I don't think anybody can give a better definition than Claire here. So I absolutely agree. I typically follow the public health stigma model that she just described. But I also think that there are two other forms of stigma that, while may not be the main conversation here today, but they are important. And one of them is structural stigma, as I see it. And the other part of it would be internalized stigma. Structural stigma, again, Claire alluded to it before. Typically, mental health services are not very well funded globally, not just in one part of the world, but globally they are not well funded. I remember a very long time ago, and one of my first areas of interest is addiction, which I do see as also a part of a mental health problem. But one of the things I remember is for the very first time walking into a clinic which provided treatment for people with substance use in the US. And, it was as far away from anything as you can possibly imagine. It was the same with the Institute of Mental Health a very long time back. If you think about it, where we were, there were no houses around us. We were like almost, nobody ever visited us. We were at the back of the beyond. So I think that is something which people don't often even see. They have good reasons for doing what they do, but I think there is a structural component to stigma, which is very strong. And sometimes it's also reflected in research fundings because they feel that what can they find out about this group of people, or how can they improve things about this group of people. Internalized stigma, I think, as most of us know, is when a person with mental health conditions tends to internalize these negative attitudes, and he feels that, this discrimination or this very, very poor behavior is kind of called for. I kind of deserve it because, I can't make it. And I think one of the worst things that happens with many young people is then, they get into this why try kind of a mode where, I'm no good. Why should I try to do anything different? So I think internalized stigma is again another area which I really do feel that we need to think more about and research more about. But to summarize it, I have always seen stigma as something not just for mental health, but for many other things in life as us versus them. And the us, as again Claire very nicely said, there is a power gradient, and the us somehow tends to always see them in a slightly different light, which is unfortunately not favorable. And therefore, they are also kept away from a lot of things, either knowingly or unknowingly. So that is how I see stigma.
Mythily, thank you very much. And interestingly enough, it's just a very quick comment from me on your last point. And stigmatization is now discussed in the context of several conditions.
Yep.
We're talking about at population health level. So we're looking at why people would go to get screened or to attend clinics or to attend follow-up appointments for condition X, Y, and Z. And you can think of all sorts of conditions. There are things that traditionally we thought about in relation to sort of cardiac functioning, this, that, and the other, and sort of lifestyle-related disease and diabetes and obesity, or even health related. So things are positive that going to the gym or walking around. Anything to do with a lot of this stuff comes with, well, if you do it, you get perceived in a certain way, and then people behave to you in a certain way, and so do the services. And if you don't, then people have started talking about stigma and looking at stigma as a determinant of uptake, and the fact, as you said, people might not want to participate in the research or might not attend, as Claire sort of implied, that in a stigmatized condition, people essentially work with their feet and they stay awake. So should we now turn, now that we understand better and we're sharing what we're talking about, should we go around, and again, maybe I'll start with you, Mythily, then go to Caleb and then Claire. Can we have some examples of, in practice, what do interventions or strategies that look to address stigma in the context of a particular condition, could be depression or it could be something else less severe, mental health condition perhaps. What do they look like? And particularly, what would be the ones that seem to have good evidence that they work? And these are the sort of questions you get you see in the Q&A. People would like to know some examples of what works in Singapore, but also further afield to sort of perhaps brainstorm what works in this space.
I think different things work. And again, Claire has done an amazing outcome evaluation of a huge intervention, but I'll let her talk about it. I don't feel right for me, it is for me to talk about it. But for us at a much smaller scale, Nick, what we did was and of course, these interventions should be based on best evidence. I think that's very important. And what we did was we used an intervention which was very typical. It's a combination of education as well as contact. So by education, I mean that just the first part of it, that misinformation that is around mental illnesses. So we had, this was done with a tertiary university. We gave talks to the students on depression, for example, and then we kind of told them what are the treatments available. We talked about how people with depression, there are very powerful people in the world with depression, who are living amongst us and who have been our idols. And then we also talked about the fact that people get completely better with, depression. Earlier the treatment, better it is. The second part was contact, which was actually a person with a lived experience of depression who had a conversation with the students. And she talked about her struggles and how she had overcome them. She was quite honest. It was not an easy journey, but, the fact that she had emerged stronger on the other side was what was apparent. In this particular study, we did find that there was a significant difference in the stigma scores before and after. And at 3 months, the stigma scores increased, no doubt, but they were still much lower than the baseline. And this was just one of kind of an intervention. So I think contact is very, very important in different ways, form and manner, but of course it has to be done very well. And I think when we see them, when we interact with them, I think it's very, very clear that there's nothing to be fearful about, and many times they are actually much better than us in many different ways. So I think contact is a proven theory for reducing stigma. The only one other thing that I would like to talk, and it's slightly a bit different from looking at it at a community level, I think is the provision of services. So instead of providing services in places which are very, very far away, or which have in big bold letters what they are actually doing, I think we are still not ready for it. We should be, but we are not. And so I feel that having especially youth mental health services, either the way that Caleb is going to talk about it, which is online, completely anonymized, or in settings like malls or settings in places where youth frequent that area. So chat is an amazing example of stigma reduction, where you can walk in if you have any question about mental health and well-being. It doesn't have to be a mental illness. So again, I think that reduces stigma tremendously, and people are able to walk in and start talking about their problems. And of course, we all know that early intervention leads to really good recovery. And that in turn also, I think, helps us in reducing stigma towards mental illness. Yeah.
Wonderful. No, now, Mythily, thank you for this. So I'll move on to you then, Caleb, because we're talking about so it could be interventions. Interestingly, we're sliding towards interventions that could directly be addressing stigma. So that's important to consider. But also, how do we take strategies that are not, where the focus is not addressing stigma, the focus is facilitating the uptake of whatever the advisory or counseling or more advanced talking therapy or other kind of therapy. What are those strategies, again, in your experience, that you've evaluated? You might be, a lot of people, interestingly enough, the Q&A you will see have questions, particularly around Mindline, the level of evaluation. What kind of things have you found that address that stigma barrier, that bottleneck that stigma may be causing?
Yeah, no, I think as Mythily was describing, I thought of like how the best people to address early mental health concerns would be your barbers, your bartenders, and your baristas. These are frontline people that are actually right in the community, ready to sort of listen to you, provide a listening ear. And by being open to speak to these kind of people, you actually reduce the stigma of mental health concerns. But side topic, on mindline.sg, I think we look at stigma as a key barrier to getting mental health support, and we intentionally design the platform in several ways. So I'll share a bit about some of our design principles when it comes to developing the product. Number one, we were very mindful to brand mindline.sg as mindline.sg and not mindline.gov.sg. I think the stigma is real, because I think people are afraid that, oh, the government is going to sort of look into my data and prevent me from getting a job and stuff like that. So we were very intentionally to communicate that it's a trusted platform, but it's also, there isn't that surveillance that's going to come through. Number two, like the big focus on anonymity, I talked about that. And just to share for international audiences, like SingPass is a way that is a national identity platform that many of the healthcare services in Singapore use. So we intentionally don't use SingPass. So we don't require anyone to log in to our platform in order to use the services, because we want to make sure that you have that low barrier of entry as much as possible. Get the help first, and then we talk about it. If you want to seek professional services face-to-face at a later stage, yes, you will then have to sort of give up some of your details so that the professionals can contact you. So that's how we work. When it comes to sort of community engagement, stigma is also real. So on Let's Talk, which is our community forum, we intentionally made it anonymous. We still require people to sign up for an account, put a username. So I could be butterfly123, for example. But we try not to make sure that people know each other's real names. We try to censor that information. When we were developing the platform, interestingly, right, and this is also research that I did together with Mythily, we found that community platforms, especially online forums, have this thing called veil of anonymity, right? When people go into the platform, let's say Reddit, you are anonymous, you feel very comfortable in sharing, but the more you share, the less anonymous you become. So when we speak to our users, they say that, oh, actually after using the platform for a while, I feel like I don't want to use the platform anymore, because I think I don't want people to know too much about me. Can I then sort of have another feature? So one of the features that was community generated was anonymous mode. So what happens is that when a user comes in to Let's Talk, they can choose anonymous mode, and they will be able to generate a new ID every 24 hours, so that their conversations don't get tracked, and they are able to then share as freely as possible. And I think this helps to reduce the stigma on the platform as well. And I think it's important, because on Let's Talk, where you share your deepest, darkest secrets, you don't want people to be able to trace back to someone, right? And I think that's the first step to addressing stigma. But there are also drawbacks to anonymous modes and stuff like that. Well, we don't have traceable data in the real world setting, because we don't know who these people are. And I think that I saw a question on evaluation. I can get to that later. But we only do evaluation in very in certain settings. We can't do evaluation in like a broad-based setting, because we don't know who these people are, and we don't have traceable data. We only collect what we need, and that's what builds that trust for the users. I'll just share one last thing that I think was important when it comes to like stigma. I think the values is also important. I think we all have some sort of unconscious bias. Even though we often talk about stigma, all of us have unconscious bias. And it's something that we are very mindful to address when it comes to building the community forum, because we don't want people to say, oh, you say this, therefore you are this. And this is something that, because we are aware of that, we heavily moderate the platform such that it becomes a safe space for people to share openly and share their contents well.
Wonderful. So I'll come back to the issue. Just a bit of a heads up before I go to Claire, perhaps to give us another example from another setting, perhaps in England, on how you might design a community-based service that is addressing or takes stigma into account, Claire. So we don't just talk about stigma reduction, but how do you accommodate that in implementing and scaling a service? But just something that was picked up by one of our delegates in attendance here, that there seems to be a bit of a paradox, where on the one hand, we're talking about exposure and training and education, and people being pretty similar to us, but there is a condition, and that condition is treatable, and so on. But on the other hand, saying we need to keep everything anonymous. So if it's all to be normalized, why, if I break my leg, I'm not going to keep it a secret that I've just broken my leg and needs fixing, but why, if I'm experiencing depressive symptoms, I need to do that to go and seek the help that I should be seeking. So keep that in mind. I think there's an interesting paradox picked up there. Claire, let me go to you to finish off this sort of round of conversation. How do we address stigma in trying to have scalable and sustainable mental health services?
Yeah, so I guess three.
Give an example.
One is really about resourcing and training, and I guess what in the UK we've called parity of esteem. So people need to see and experience that mental health services are as equally well resourced, accessible as other services. So they're not in kind of dingy buildings, or as Mythily said, really far away. Because that's a very kind of strong message that's conveyed by making something nice, basically, to visit. I think another thing is that it's not just about making community care be in the community, but with the community. So you have to be a good neighbour and work with other community organisations and the community itself, rather than just sort of sitting there, in your team base without really kind of reaching out, because I think, the fear that the public has about community care, about people in the community. Every time there's an episode of violence, for example, that gets a lot of media coverage, you can't just wish that away. You have to address it with people, and you have to acknowledge that, for example, if you're a mother with small children, that kind of thing is frightening if it's happening in your community, and that requires a degree of kind of public education, I guess, and so that people feel like they know what to do. If they see someone who's visibly unwell, for example, on the street or public transport. And people can contact services and get a response, so that they feel kind of empowered and less fearful. And that's really what I mean by being a good neighbour. And then I guess the other thing is just touching on what Caleb was saying about our own stigma and conscious or unconscious bias, is the fact that that clinical contact can actually be not always something that kind of reduces stigma, because we see people when they're at their most unwell, and the people who are most severely ill, and everyone else is doing okay, we don't see them. So we kind of forget about the fact that people recover, and there's a sort of a bit of a chicken and egg situation, which again I think we've sort of touched on in a way, that if people feel like they need to avoid stigma by being anonymous, you don't see, you don't know about the people who are fine, your colleagues or whoever, who have been unwell, or maybe continue to have some symptoms but are doing fine. That's not visible. And until those people feel able to disclose, or until you're working with people who are employed, for example, as peer support workers or peer researchers or peer educators, depending on what sector you work in, then you won't have that positive contact to counteract the kind of, the burnout and the loss of empathy that can happen when you see people who are, like I said, at their most unwell, and particularly if you get frustrated about not being able to help people as much as you want, the way that can kind of wear you down. And the same thing happens obviously with family members as well, so there are types of contact which can essentially reinforce stigma because of that ability to help, or only seeing kind of one side of the problem. So the nature of contact is such that it needs to not just happen once, but it needs to kind of be repeated, and you need to be reminded, particularly if you work just in acute services. You need to see how much better people are once they're no longer on your inpatient unit, for example. And that needs to be something that you kind of repeat throughout your career, really.
No, Claire, thank you very much. So I'll now turn back to perhaps Caleb and Mythily again, just to revisit that issue of anonymity. And is it causing some problems or slowing us down from addressing some problems? What will be your take on that? The question we have in our Q&A.
I'll go first. I think it's a very relevant question. It is something that it's not something that we haven't pondered about or thought about, and the person makes a very good point. On the other hand, we have a treatment gap of 75% for majority of the mental illnesses worldwide. And if you ask people, the number one reason for not seeking treatment remains stigma in many different places. And it is really because these people feel, the person who has the mental illness feels that they will be discriminated against if they come out and they talk about it. And while one way of looking at it is, you have to dare it, you have to do it, and then you see nothing will happen. That's one way. And it may be true in certain situations. I'm not denying it. But we also have to look at it from the person's perspective where they have probably been their responses are probably due to things that they have experienced or that they have seen. I have had many people tell me that they have lost their friend circle. People's, family members don't really invite them to gatherings or to places because they know that this person has mental illness and they're just not very sure how this person will react or they will do something. So many people talk about how their social circles are narrowing. People do talk about being kept out of promotions. There's a kind of a extra glass ceiling for these people when it comes to having career opportunities because people are scared they will not be able to handle responsibilities. So sometimes it is important to understand why do they feel that way, and in some cases they may have seen this in other people happening. And unfortunately, when you see it in a family member, that kind of gets ingrained even more. Especially I've seen it in siblings. My brother had that and this happened, and I don't want to talk about it at all to anyone. I think I can manage it on my own. So when we think about it from the person's perspective, I think they have the right to anonymity. I think everybody has the right to anonymity, whatever the medical condition. We can't expect people to declare that. But I agree that I would like to think that what this person says is absolutely true. And at some point of time, we will reach a balance where society is, in fact, more understanding. I won't use the word tolerant, that's not the right word, but people understand mental illnesses better. And therefore, when that happens, I would like to think that there is no need for this anonymity. And exactly as Caleb said, I have a broken foot, I need to get it treated. I don't want to hide it, I can't hide it. So I wish that would happen someday. But Nick, the reality is that people are genuinely scared to come out and talk about it.
No, understood. And the consequences at an individual level that we're describing here are very, of course, real. So, but it's, again, we're handling a topic here. We're not giving a silver bullet answer, right? So there are tensions and there are choices to be made in the design of these services in terms of the immediate sort of alleviation, if you like, of the disease, the burden, and the 75%. I mean, that's a shocking statistic, really, Mythily, of the need that's unmet, the treatment need that's unmet, and on the other hand, looking at medium to sort of longer term solutions that will achieve that more societal, scaled sort of change in change in perception. So Caleb, on to you for a comment on the same sort of aspect, because again, you're at the core phase, as they say, of designing and implementing and continuously improving the interfaces that come under you guys.
Yeah, I think it will take time, and I think maybe Mythily can share more about the Mind Matter study. I think we've seen an increase in understanding of mental health conditions over the last 7 years. So I think that's a sign of progress. We're not at a level where we can all be very open about it, but I see us making small steps, making progress. But from a design perspective, I think, and especially when it comes to designing tools and digital tools, we shouldn't just accommodate stigma by making it completely anonymous. I think we need to soften stigma over time. And I think there are 3 things that I think could help. Number one, normalizing help seeking, in a sense where we do a lot more public campaigns. Campaigns in Singapore, like the Beyond the Label campaign, have been very successful in normalizing help-seeking behavior, getting people to share their own sort of concerns. So on Let's Talk, we get our peer supporters, our befriended to share their own concerns. So when you are someone who wants to seek help and you see someone who has shared their experience of meeting the therapist for the first time, you feel more empowered and feel more confident in what to expect. And of course, it may take time for you to find the right therapist before you get your condition addressed. But at least it helps you to manage the expectations and reduce that fear a little bit. Number two, I think offering both anonymous and visible modes of support. So I think on Mindline, we have that anonymous option, but we also have that option where you can seek in-person support for people who are more comfortable. So I think even when it comes to, I mean, this is a sidetrack, but when it comes to generational preferences, I think the younger people that we see tend to lean towards the text-based support, but the older people actually prefer to seek in-person support where they can sort of share in person. I think that's just the generational difference, but from a design perspective, we do need to offer both forms, both anonymous and visible. And then lastly, it's about helping users transition from that self-help mentality to seeking professional support. So we often ask people on Let's Talk, are you ready to sort of seek professional support? If you are, here's the steps that you can take. We always leave that choice so that and also support them through that journey. So it's important to always keep that that option open, and not just keep them on the self. We don't design our platform to make people addicted to us. that's a very important point. We're not like TikTok where you scroll endlessly and doom scroll, but we are here to always make sure that you get the right level of support at the right time.
Yeah, Nick, if I may add just one point.
Please.
I mean, yeah. So I was just thinking about what Caleb said, and I agree with that age factor that he talked about, because for us, when we, for example, I have conducted a focus group discussion, we usually have a mixed age. And so I found that the middle-aged and the older age people, we were talking about stigma actually in that focus group discussion. And this, they said, don't tell anyone, if you tell anyone, you will be looked upon differently. And I'll never forget this very young girl, university student, and she said, why not? I don't think there is anything wrong. And she said, if they want to avoid me after that, their loss. I'm okay with it. And I think my good friends will actually stay by me, and people who value me will stay by me. So I agree with Caleb that there is, and with you what you said, there is a generational change. And I think, that things will change over time. Not everybody will be as brave as this young girl, but there are many people now. So I also think, as Caleb said, we just need to give it some more time.
Wonderful. So thank you very much for this. So the questions are indeed coming thick and fast. So in terms of time management, we've got about 5 minutes, and I want to take us to one theme of identifying the questions. Again, for our audience and our delegates in attendance, remember that one of the things that we do, we collect and collate those questions, and we ask our panelists to provide some written responses and links to documents where you might find some more of that. For example, some more of Caleb's data in terms of how Mindline works, who they screen, and what evidence who uses it, what they come up with in terms of questions and stuff. So some of this will leave for after the live webinar. But the final thing I want to bring up, because it appears in different ways in some of these questions, is the sort of the balance of risks and benefits with digital. And by digital, I'm using the term very broadly here. We talked about it. Perhaps it ensures anonymity. We just debated this. People are talking about the relational aspects. Can you maintain that? And I know, and I've been part myself for several reviews we've done in terms of remote delivery of services where, people are therapists and healthcare providers are debating, can you actually develop and maintain that therapeutic relationship with a patient or your client? And also there's another comment about over-reliance on large language models, which tend to come now left, right, and center in the evidence base. People are using them in lieu of a therapist. Some really odd case studies appearing in my LinkedIn feed for sure about how spouses are commenting on each other's behaviors following advice from ChatGTP amongst other LLMs, but not singling out one of them. So perhaps a brief comment. You've got about 1.5 minutes each to comment on that. Where do you think we are? What might be the sort of things to look out for and study in the future in terms of advanced digital technology, in particular large language models that are seemingly coming to stay with us for the next generation?
Caleb first.
Whoever would like to go first on that. Whoever would like to go first.
Okay. I can go first. I have a lot of thoughts, but I'll try to keep it brief and maybe just focus on the AI components. I think that's something that we look into very, very much. And I can probably say that from my own perspective, I think generative AI at this point in time is not ready, even though, I mean, there are many reports saying that, AI therapy is the top use case for generative AI right now. People are using it, but I think we are not ready, especially because many people who are using large language models for therapy are using general purpose models. They are not built for therapy. Yes, there are very superficial guardrails that are in place, but there is still that risk of hallucination that could take place, because technically, like, they are just generating words afterward, right? So there is still that slim chance. So with regards to what we do here in MOHT, we do use generative AI, we do explore, but we don't allow generative AI to go direct to clients and patients, especially in the area of mental health, where we are dealing with vulnerable individuals who may be at risk. So we are very careful of that. We do have an AI chatbot on the platform. It's called Wiser, but it doesn't. I think I'm frozen. Sorry.
We can still hear you. Yeah.
Okay.
Maybe a couple of concluding thoughts on that, and then I'll move on to our other panelist, Kelly.
Okay, yeah. So I think it's important to make sure that generative AI is there are sufficient guardrails. So in MOHT, we don't use generative AI in Wiser. It is still a rule-based AI, and I think that allows us to vet every response that the chatbot gives to our users. So that's very important. So I guess in summary, AI safety is a big thing. We need to sort of be very careful.
So AI safety, we take there as a theme, and that's a focus for current future work. Mythily, and then Claire, you will conclude for us.
Nick, I'll go with the online, whether we are able to have a therapeutic relationship with this thing. And disclosure, a bias, I'm definitely on the other side of 50. So do forgive me. It's because it's my own age-related issues coming here into play. And what I mean by that is I do feel that older adults do struggle a fair bit with setting up just the technical details when they have to come in online and get involved in a therapeutic intervention, or when they have to take in information. We are doing currently a study where we are trying to provide psychoeducation online. And when we are doing this, we do see that older adults need help for just setting it up. They are completely lost. Volume sometimes is an issue. Other things are an issue. So I do feel that, digital literacy is something that we have to think about very, very carefully before we just decide to go online with everything. Of course, younger people are much better. With younger people, on the other hand, again, my own bias is a lot of people don't switch on their camera. I have no idea whether they are paying attention to me, whether they are paying attention to something else. So again, I don't get a very strong feeling of having a good therapeutic relationship with them. I'm not saying this is always the case, but sometimes these are some of the drawbacks that I do feel happen when we deliver things online. Having said that, reach is much better. And let's face it, the cost effectiveness is much better. So not something that I'm saying just dismiss it, but I think we need to overcome some of these challenges.
Thank you, Mythily. Claire, the last word will be yours before I conclude, and by thanking everybody.
Just to say, don't kind of reflexly go always to online if it's young people, because there are some who would like face-to-face in addition. I mentioned school-based group cognitive and behaviour therapy, parent-led CBT. There are other ways to deliver this in a face-to-face relationship, which young people may appreciate.
Okay.
Wonderful. So this is the end of the allocated time that we had, and predictably we have far more questions than time to handle them. Also, thank you to all three of you. Thank you, Claire, Caleb, and Mythily. Thank you to the wonderful BISI production and administration team that who all helped over several weeks to pull this webinar together. We're absolutely delighted to have been able to do this. And of course, a very big thank you to all the people in attendance, all the questions, all the thought process. We'll be trying to address as many of these as we can. We'll put it all online. A very big takeaway, two big takeaways from me. There are interventions that work. We can scale thoughtfully. Again, we don't have silver bullets. Tailoring seems to be the flavor of the day, because interventions and delivery mechanisms might work. Different interventions, delivery mechanisms might work for different clients. And of course, one of my BISI colleagues, Tong Xiao Chen, has just picked up the fact that we are really talking about systems level thinking. So we're looking at individuals, we're looking at teams and organizations and the provision of care, and we're looking at societal level impacts over time. So quite a big complex topic that I think we should be revisiting it in a few months' time with a follow-up webinar. Thank you all very much for attending. It was an absolute delight to have this conversation. Wishing everybody a very good evening, and join us again in the future for subsequent events. Thank you. Bye.